and give a presentation on that today. So Matt is the privacy officer for the Washington State Healthcare Authority. His office is responsible for the agency on compliance with healthcare privacy laws, and he works across the agency to help with outreach and implementation of a wide range of healthcare authority programs and initiatives. And before joining the Healthcare Authority, he was an assistant attorney general advising the Healthcare Authority and DSHSS on privacy issues and other aspects of the state's Medicaid program. And before he talks, he wanted to share a video, and I will play that now. You gotta share the right screen though. One moment. Still not sharing the right screen. One thing about Zoom. Here we go. I believe the audio will come to from my computer. We couldn't get it from the owl.
Hi, my name is Sharisa Patinos. I'm the Deputy Chief Medical Officer for the Washington State Healthcare Authority. I'm a family medicine and addiction medicine physician, and I've helped to sponsor this toolkit. 20 years ago, most people thought addiction to drugs or alcohol was a choice, a weakness of character. This thinking led to discrimination and a law enforcement-focused approach to treatment. In order to protect people from discrimination, strict federal privacy was put in place. While well-intended, the rules are complicated and hard to understand. This has led to barriers in sharing important information across different disciplines of care. The very good news is that today there are effective medical treatments for opioid use disorder. There are also behavioral therapies that can help people with other substance use disorders. This toolkit is meant to help medical, mental health, chemical dependency professionals, and patients understand how a person's information can be safely shared and protected. In order to better manage the whole health of a person, which includes their mental health, their substance use disorder history, and their physical health, better sharing of information needs to occur across healthcare disciplines. Substance use disorders are medical conditions that are treatable. Perhaps when healthcare providers become better at asking about substance use and sharing this information with other health-related disciplines, there will be less shame and trying to keep hidden treatable conditions.
So Matt, I will let you share your screen. You have the floor.
Okay, can you see my screen?
We can.
All right, excellent. Well, thank you for the introduction and thanks for having me. I always like to start out with that video from Dr. Fatinos to set the stage a little bit and be able to speak from a personal experience. I want to quickly go through an agenda here and then we will dive in. So briefly, I want to talk a little bit about the issues with implementing 42 CFR Part 2, those privacy that govern SUD information, and then talk.
Matt, we lost you.
About the healthcare authority's next steps. A couple of caveats before I get started. The first is that I normally give this presentation with Amber Sexton, who is our data governance manager and wasn't able to join us today, so please bear with me a little bit. And the second one is that this is really intended to
I think it's our internet, even though I thought it would be stable. Matt, can you hear us?
So with that in mind, I am just going to give an overview, but I'm open to any questions if anybody wants to dive deeper on any of these topics. So first thing I want to talk about is just the basic reason why 42 CFR Part 2 is an issue for care coordination specifically. And that is that under HIPAA and under our general state privacy, that seamless integration between providers for all the care that the person's receiving. But there's a fundamental SUD information. Not only are there not exceptions to share information for things like payment, kind of administrative functions, you also can't share that information even and if that facility had an SUD facility as part of it, even within the same building, those providers won't be able to talk to each other without consent, which can create barriers to integrated care and prevent those providers from really understanding the whole range. One of the reasons that this law is particularly kind of complicated and difficult to implement is that it was also developed on, or when I say it, I mean Part 2 was developed on a completely different than other healthcare privacy laws. So when we think about HIPAA as being kind of the normal baseline for privacy laws and what everyone's
Hear us at all.
in contrast, Part 2 was originally created in 1972, and until recently, it hadn't been updated since 1987, which is also the year.
I think it's our internet. Can your phone? It's on speakerphone. Tell him that we can't hear him.
Matt, can you hear me?
I can.
And I think our internet keeps, I think it's our stability. Is anyone else on the phone having a hard time with it cutting in and out, or is it just us in the room?
Wendy, the phone seems to be very clear on my end.
I talked to an audio guy here. You can continue.
Wendy, this is Rebecca, and I can hear fine.
Thank you.
Okay. People who have been following this closely would know that there have been changes recently, and it's been a pretty hot topic at the federal level. In 2017, there were some updates to the rule for
Texting with the audio guy.
but fundamentally, the basic rules and the basic challenges that the law has created were not addressed. It continues to be discussed. Last year, there was legislation that passed through the House almost unanimously to change Part 2, or the legislation that underlies Part 2. Then it's been reintroduced again this year, and we'll see what happens. The other thing that's happening is that SAMHSA has been considering further rulemaking. You'll notice that on it's already out of date. It says that there was supposed to be rulemaking proposed in March of 2019, which is come and gone without a rule. But especially if were the biggest gaps at the state level, and that's what you see on the right here. And the first one was really the people, that there's just an inconsistent understanding of Part 2 that's affecting people's care. There's also a lack of policies and processes at the state level to help alleviate that inconsistent understanding. And then the third one is that from a technology perspective, even if we had perfect understanding and consistent understanding across the state, there really aren't health information technology tools in place that will allow it to be implemented effectively. So at this point, in this particular toolkit is really aimed at to come out that will be in a better place to implement them effectively. So just a little bit about this process that we've been working on for a little bit over a year now. We didn't want this to be just a healthcare authority effort, particularly keeping in mind that we wanted this to be something that could establish a common understanding and not just HCA's understanding. So we convened first a work group of state agencies that touch healthcare. So we had the Department of Health, Department of Labor and Industries, OFM was here, the new Department of Children, Youth and Families, OSPI, any agency that had some type of health program within it, helped collaborate to think about what would help people in the community understand the law and what the common issues were. Once we had a draft of that, we widely circulated it with community partners. Again, keeping in mind that a product that doesn't help people understand the law or that isn't accessible wasn't going to do much good. So during that phase, we tried to select a variety of providers of different sizes, of payers, community partners like ACHs, and that was also a very helpful process. And then just in the last month or so, the document was finalized and published. So I think I've gone over this for the most part. The idea is, again, that we wanted these materials to be created in a way that could speak to how people deal with information in reality. So in addition to kind of the basic legal guidance, we also wanted to create tools that could actually be used or could help illustrate the issues. So one of those is things like real world scenarios, like walking through how this information may need to be shared in reality. A sample consent script for providers to use who are not comfortable asking for this specific type of consent. An informational brochure was another one, and then a Part 2 compliant consent form that implements recent changes to the law. So what I'd like to do next is just walk through some of the basic sections of the guidance. And then after that, I think I'll give you all an opportunity to ask any questions you may have. So one of the common questions that comes up about Part 2 is who is subject to it and what information is subject to it. So we have a whole section of the guidance that is aimed at walking through the process to determine if you're subject to 42 CFR Part 2. And what you're seeing now is a decision tree that's kind of the culminating piece of that section. But in addition to this, it also goes into some more detail about some of the stickier issues that we encounter. So one example would be a primary care physician who provides MAT, and whether the fact that they're providing that medication-assisted treatment makes them subject to Part 2. Another one is what happens when there are co-located services and you're treating somebody with co-occurring disorders, and is all the information subject to Part 2 or only some of it, and how would you go about drawing those lines between the two? So that kind of background information, again, focusing on some of the most frequent questions that we were receiving. Another section that I already talked a little bit about were the real world scenarios. So for this section, we tried to imagine a person who has a substance use disorder and is receiving services from a wide range of people. That could include their physical health providers, it could include an ER provider, inpatient or outpatient SUD providers, and trying to then use that basic diagram to explain how these different people who are involved in the person's care could exchange information with each other. And through that, we also wanted to highlight that there are also at least a few examples where information can be shared without consent, and make sure that people understand that those exceptions do exist. So here is one of the actual scenarios, and this is one of the scenarios where information can be shared without explicit consent, which is when there's a legitimate emergency and it's not possible to obtain the consent. And you see that we have the general description of the scenario, what the flow may look like from the time the person arrives at the provider and how they would exchange that information. And then an explanation of what the rules are under Part 2, and also what the rules are under HIPAA and our state healthcare privacy laws and how those may interact. Because there are some circumstances where HIPAA or state law are actually more stringent than 42 CFR Part 2, and you need to make sure you're following all of them. Another section that we included was the requirements for a 42 CFR Part 2 compliant consent form. And we thought that this was a really important area to focus on. This is not a form that we are requiring anybody to use, and it's honestly not even a form that I necessarily expect people to implement in its current form, or to print it directly as it is and begin using it, although you certainly could. But what we really wanted to do was show how some of the recent changes to Part 2 could be implemented, because going along with that idea that there was an inconsistent understanding in the state about how this law works, I think that there's an even more inconsistent understanding about those recent changes in 2017 and 2018. So I think the biggest example of that is that you are now allowed to gather a consent form that allows information to be shared with all treating providers for care coordination purposes. So before, you used to have to specifically list every person that the information could be shared with, which obviously could be extremely burdensome or impossible, especially if at the time when a provider is asking for consent, that person doesn't know who their providers are going to be in the future. I will offer one caveat, though, that although this change exists, it's not particularly easy to implement. There are some difficult administrative pieces that come along with it, but we still wanted to show that it can be done. So this is just a basic overview of the different parts of the consent form. And I want to skip to Section 2 reflects one of the changes in the law, which is that you are also now allowed to have a single consent form that allows information to be shared by all providers. So all the SUD providers who have information about a person can rely on this same consent form. So again, before the requirement was that each provider who was sharing information was specifically listed on the form. And then Section 3 talks about the change I was mentioning just a minute ago, which is that you can now have a single form to allow treating providers, or all treating providers, to receive information. And here we wanted to make sure that we incorporated this change in a way where it could be implemented, but also to continue to respect the person's right to choose who their information was shared with. So a person could select that they wanted to share with all treatment providers, or they could still do what has historically been done and choose to only share with people that they specifically identified and listed. And the hope is that this type of form and selecting options like this will make it easier in the future as we move forward with technological solutions to implement actually managing the consent. Another section that was added with the help of Dr. Fatinos was a provider script. So we know that one of the barriers to allowing the sharing of this SUD information is that it creates a burden on the clinical process for that provider who's gathering the consent. And there are some providers, obviously, who are very comfortable asking for consent and receiving it, and others who are not. So this was really an idea of just setting out a template that people could use and adapt if necessary, and to work into their own clinical workflow. And the last thing that I wanted to touch on here is a brochure that's intended to be used, or I should say, to be available for the person who's receiving the services. I think we're probably all accustomed to seeing an explanation of privacy practices that are really covering HIPAA. You'll see them in the waiting room when you go into a provider. They're widely available online. But there's not very much out there that really talks about part 2. So we wanted to have, again, a more accessible explanation of what this law actually means and how a person gets to control how their information is shared and who it's shared with. And really to present it in a way that makes sense for the person, and as opposed to just being kind of legalese to protect the provider who's gathering the consent. So those are the basics of what I wanted to cover. Again, this is just an overview. The website is live now on hca.wa.gov. If you even just Google HCA consent management, you'll get taken to the page. But I did want to provide an opportunity if anybody had any questions.
Yeah, I have a question. So if I understood you right, you're saying if in a primary care, I guess you call it a physical medicine provider clinic, if they're providing MAP therapy, they don't need to obtain specific consent to disclose substance use treatment. Is that what you're saying?
That's right in most circumstances, yes. As long as it's not kind of their primary role and they're not holding themselves out as an SUD provider, that's correct. And the document does walk through that logic and the questions you would want to ask yourself to make sure that you're compliant.
Any other questions?
So do these rules pertain just to licensed or certified behavioral health or substance use disorder providers who do put themselves out there as that kind of provider? And maybe I'm asking the same question. Does it just apply for those who are licensed or certified by the state as a substance use disorder or a behavioral provider?
So the law actually doesn't tie into state licensing or certification requirements. The way it operates is that the test is basically whether the provider holds itself out as providing SUD services. And again, it's kind of a vague term, and there is a little bit more explanation of exactly what that means in the document. and whether they receive federal assistance. But again, the definition of federal assistance is also very broad, and would include kind of almost any type of grant funding or even receiving Medicaid payments. So trying to think of another way to answer the question. It does not apply to, for example, a primary care physician who has somebody come into their office and self-discloses that they have a substance use disorder, and that gets documented in that provider's clinical records. That is not the kind of thing that Part 2 is intended to apply to, if that helps.
Anyone on the phone have any questions?
I have one more question. So as a substance use disorder provider, one of the issues that we see with this universal consent is when someone wants to revoke the consent from an individual provider. So is there any work going on around that?
Yes, so I think that gets into that technology piece, that although we can create the form now to be effectively implemented, you really have to have some type of technology that can implement the consent in a scalable way. So that means you need to have a system that can include all the information about that consent. When does it start? Who can information be shared with? And then also, where does that person go to revoke consent so that it gets kind of uploaded into that consent management system? So work is ongoing around that, but I don't have a specific update on when there'll be more detail about it.
Thank you.
Anyone else? If you're online, Caroline put the link to the website in the chat box. For those of you in the room, on your agenda, you'll see a bit.ly link on that section that will take you to the website with more information. There's some informational videos there. There's also the guidance document there that you can take a look at. It's a fairly lengthy document with several different scenarios that may help you. Any